part of a larger project I'm working on in relation to trust autonomy in medicine, both in therapeutic and research medicine. As Dr. Sismondo just mentioned, I think you mentioned that I'm in the philosophy department at UBC. And part of my interest in doing this project, at least what we're talking about today, is focusing a little bit on issues about trust in institutions. There has been a lot of work on trust in interpersonal kind of relationships in bioethics and philosophy, but there hasn't been as much work done in trust in relation to institutions, even though that has been a prominent issue that being discussed in many other fields in political theory, STS, and so on. It seems that philosophers, we're always just a step behind. And so I want to maybe think a little bit about how do we think about trust in relation to institutions, and what may that look like. Part of my motivation here is because I work on, or I work with a research ethics board, and I do other kinds of ethics education. But one of the things I feel kind of dissatisfied with is that a lot of the focuses has really, in relation to trust, has been mostly actually on informed consent. And actually, I should perhaps even backtrack a little bit. A lot of the work in ethics in relation to sciences, medical sciences, has been mostly focusing on autonomy. Trust hasn't really been the same, or at least doesn't have the same kind of foundational value as autonomy, privacy, or rights may have been having. So there has been a lot of work, like I said, on individual trust relationships. So mostly we're focusing on how may a particular researcher or particular physician may interact with a particular patient or research participant. So usually we're focusing on whether the professional is coercing or manipulating a specific subject or patient. I suppose that there has been actually a lot of concern about that, and perhaps rightly so. But I want to think a little bit about whether that particular individual focus is legitimate here. Now, there has been an assumption that medicine is a profession that is embedded in an ethos of service. And so in general, when we talk about trust, there seems to be at least a background assumption that patients and research participants can trust physicians and medical scientists to do certain kinds of jobs. At least there hasn't really been that much concerns about competence of researchers, although concerns about reporting errors may have been a concern here. But the other part that I want to think a little bit more today is the whole confidence in the goodwill of researchers and physicians. Generally, again, when we are talking about interpersonal kind of relationship, we seem to take that for granted. We seem to assume that physicians or perhaps even research scientists are somehow encapsulating the interests of the public or the interests of patients in their kind of work. But there are now perhaps questions in terms of whether we can still take that for granted. Surveys have shown that there is a sharp decline of trust, even in interpersonal trust in the last few decades. In 1960, more than half the people would answer to the question affirmatively whether most people can be trusted. That number had gone down to 33%. Even though confidence in medicine has been quite high, especially in terms of confidence in individual physicians. Usually most polls would still show that people, about 80-some to 90-some% of people would still say they trust their particular physician. But as an institution, the confidence level has also dropped dramatically from 70% in the 60s to 29% in 2002. And so for other institutions, that number hadn't changed as much as the number in medical institutions. And this number especially is a concern when we're thinking about certain marginalized groups. Women, when they talk about their trust in physicians and the medical enterprise, people of various other kinds of marginalized identities have all had a lot more mistrust in terms of whether they, for example, now would like to actually enroll in any kind of medical trials. So now with the decrease in trust in institutions, there may be questions whether that is actually going to also lead to some kind of decreased trust in particular professionals. like I mentioned earlier, I don't think that the decrease of trust is so much about decreasing confidence in professionals' competence, but there seems to be a lot more concerns about professionals' goodwill, even though supposedly it's generally believed that medicine is embedded in this ethos of service, but there seems to be some kind of changes in structural framework that has led many people perhaps to be a little bit concerned about what some of these encounters are going to look like in the future. In the mid-20th century, this is mostly thinking about therapeutic medicine, encounters with physicians were somewhere between 50 to 20 minutes, but that has gone down to 5 to 8 minutes. And now there's also more I guess, push for e-medicine. So there may be questions about whether there's even that kind of interpersonal sort of relationship there. And with healthcare teams, of course, there are definitely many pluses for healthcare teams, but there also has led to some kind of discontinuity of care. Patients are no longer seeing the same professionals, so they really don't have that kind of, again, interpersonal relationship to base their trust on. So in general, what they really have to do is really rely on the institutions for the competence and the goodwill of the professionals that they may interact with. However, if the number that we just looked at is any indication, we may be in trouble. Right? If we have to actually rely on institutions to think of our professionals as being accountable, and that number keeps going down, and then that may also affect the way that patients and research participants may interact with the institutions. And there has been, especially in the last 30 years with the bioethics movement, there has been a lot of concentration or focus on talking about patients' interests. But it seems that that particular so-called rhetoric, I want to say, is the rhetoric of the patient interest or so-called patient-centered care is very much hiding various kinds of changes that is lurking around in the healthcare structure, and perhaps also ignoring the social context within which many of these encounters take place. So I want to look at 4 specific institutional considerations here today to think a little bit more about why we really need to think of the conflict issues and autonomy issues and trust issues, not just in relation to interpersonal kind of encounters, but more as a systemic issue. So the first one I want to look at is the whole institutional power structure. Like I mentioned, in general, philosophers and bioethicists have been talking a lot about power as a dyadic kind of situation. We're talking about a particular physician and a particular patient, or one particular researcher and a participant. Whether the consent process within these or very small kind of relationship is coercive or manipulative. But power and domination are not really just individual kind of actions. In terms of how patients may respond or how potential clinical trial participants may respond to various kinds of information is very much embedded in the social structure and a very complex set of practices and policies and unequal power. And so if we really want to understand professional relationships and the behavior of individual patients and participants, we really need to look at how exactly those professional relationships play out. So what I want to say is that even though we keep talking about autonomy in an individual sense, it actually doesn't really get to some of the issues about power and oppression that is still very much dominant in the medical field. And this is, again, especially the case when we're talking about various marginalized populations. And as we just heard, that a lot of the clinical trial options and what may now be seen as even treatment options are now more and more corporatized, is that such a word? Corporatized? Commercialized. And so a lot of the decisions, especially in the United States when we think about managed care, a lot of decisions are really not so much based on an individual patient's preferences, but more on what these third-party individuals and institutions may have in place. So commercialization, we already heard a lot of the statistics and data about how it has been changing the framework of we think about science. I remember last year, so my UBC colleagues, maybe you don't want to hear this, but last year when I started teaching there, I went to the new faculty orientation. And and there were not that many humanities people. There, most of them are science people, and they kept talking about what kind of grants they were bringing in, and there were all these charts to show us how many patents we've got. And I think by the end of that day, I really felt I was like sucking up the university's resources because I wasn't bringing all these other things from the industry. Now, of course, the industry may have a lot of contributions to some of the work that we're doing, but there is that kind of, to me, sort of conflict in terms of, especially in university kind of situation, who we think we're about. So the privatization may also be changing the way that we think about who actually are in that kind of relationship. Are we really talking about professionals now with patients, or are we talking about now providers of various kinds of consumable products here? Just some other numbers again with R&D investment by private companies. That that's also we saw earlier too. That nowadays that private investments is much higher than actually what state or what governments are actually providing. So there may be questions again about how do we want to reconcile that. Again, then when people, especially when consumers realize that this is what's happening, actually also affect the way that they may trust their particular physicians. And also, of course, in many ways also affect their access to actually any kind of medical care. In some situations, especially in the States when people are not insured, if they have no other means of actually accessing certain kinds of care that they need, they may have no other route except to enroll in clinical trials. So that may also get to the question about how autonomous we think some of these decisions may be. And this is especially the concern when we're talking about certain marginalized populations that are historically underrepresented in healthcare. And one other issue that I want to say a little bit about is that when we talk about conflict of interest, when we have also physicians now who are owning more and more diagnostic and therapeutic services, then you have a situation of self-referral. Then how do we deal with some of those kinds of conflict there? Well, there's some who have actually argued that conflict of interest, in a sense, is just inevitable. Perhaps it may be more a question about how much of a conflict of interest that may be. And there may also actually be questions about what counts as conflict of interest. We usually think a lot about the financial situation as part of the conflict, but some people may say, well, perhaps there are other kinds of interests that may also be perhaps affecting a person's judgment. Or may affect the person's different kinds of roles here. Like I mentioned, some physicians may also be clinical investigators, and in some cases they may actually be self-referring some of the patients to their own clinic or to their own diagnostic labs, or in some cases maybe to their own clinical trials. So blurring that role, I want to say, is also exploiting that trust. And what I mean there when I say exploiting trust is that sometimes it doesn't even necessarily has to be the case that the outcome is undesirable. You may have a situation where the outcome in the end is fine, but I want to argue that that is still some kind of exploitation of trust, especially because many patients actually don't know how to distinguish the role of a physician as a physician versus as being a clinical investigator. And so when we have these particular types of conflict of interest, very often it also gets very tricky in terms of figuring out what each person or each party is actually owing to different constituents. So now there may be a question in terms of whether we should have more regulations to fix some of the problems. And it seems that, oh, I missed this slide. Sorry. Yeah, okay, so before the regulations. So given the conflict of interest, that there may be questions about actually whether we think that people generally really have that kind of autonomy that many, I guess, ethicists want to say that is in place, or many perhaps even scientists want to say is in place. Supposedly, individual autonomy is a foundational value of Western philosophy and bioethics. We have a lot more concentration now when we talk about patients' rights in relation to informed consent, like I mentioned. But the assumption generally is that the people who are, for example, signing consent forms are articulate, educated and intelligent individuals who are on equal grounds with professionals, and that they're not affected in any way by the power structure. But other bioethicists like Sue Sherwin, especially using the feminist framework, would say that actually there have been a lot more concerns about whether that model is actually realistic. Sometimes just think about even for most of us here who are educated individuals, when we go to a doctor's office, when they ask, so do you have any questions? Right? I often wonder, what exactly should I be asking? You have to really know exactly the kind of questions to ask before sometimes before you actually get some of the answers. But most people, in general, would not actually know what to ask. So the informed consent model, it seems to be a little bit lacking here, especially because it seems that people, when they actually come to a trial or when they come to the doctor's office, they're given some kind of predetermined menu. So a patient does not necessarily know that there may be other kinds of clinical trials, there may be other kinds of possible procedures out there that have not been presented to them. So autonomy is really just choosing in a much more limited sense. And especially when it is a case of power dynamic, most of the time people actually wouldn't say no to anything that is being given to them. And at the same time, informed consent perhaps would tell us that the patient has read maybe part of the form, the signature line usually, right? But it doesn't actually say anything about whether that particular research is actually worthy to be pursued. So usually by the time that you get there, everything has already been set up. The only way that you can actually choose is be in or be out of that particular trial. So now can regulations or other kinds of codes of conduct actually change the situation here? I think supposedly institutions that have various kinds of licensing requirements, codes of conduct and regulations can somehow enforce sanctions and hold members accountable. It may, at least in a sense, give them a little bit more of an idea of what is actually expected of them. But there are also concerns about, I would say, IRBs and RABs that are self-regulatory, which is perhaps the whole model of medicine in the first place. And again, most of the time, what is being really looked at is the whole situation of consent and informed consent. The research plan is already set. Sitting on one of the IRBs at our university, by the time we get the materials, everything has already been planned. I don't know if I'm not on the clinical board, I'm on the behavioral board. We have not rejected one particular research project. I'm not saying that we should try to do things like that, but just in the sense that everything has already been predetermined. And so by the time that we get it, it's really mostly how the game works. It's mostly just to look at whether the informed consent is adequate in a particularly prescribed sense. But also we can't forget that many of the trials that have been done, especially in the US, the more well-known ones like the Tuskegee, Willowbrook kind of examples, all happened after the Nuremberg Code has already been established. So we can ask the question of whether we really think that some of these codes are actually always helpful. And also with the self-regulation, there are also concerns about whether there may be actually also conflict of interest within some of these ethics boards. Sitting on a board, my colleagues don't agree with me on that. I often think that every time is by itself a major conflict of interest. There isn't as much study on that. We're basically evaluating our colleagues' research, and most of the time, I think maybe it's actually all the time, they cannot, if it is a funded research, they cannot get the money until we have actually approved it. And I don't think anyone really dares to reject a particular project that actually has been funded. So there may be questions in terms of whether that by itself, that the whole system itself, it already has some kind of inherent conflict of interest that perhaps is irreconcilable. So now, if we have any kinds of sanctions, one of the questions that we may want to think about, but perhaps we can say, now that with more and more aspects listed out in various contracts, may be a sign that we don't trust each other as much. And regulations, I don't know, maybe Joe is going to talk a little bit about this later on too, they don't always actually apply to also the private sector. And with outsourcing research, we may also have concerns about whether some of the international research would not be actually under the same kind of regulations. So I just want to maybe say a little bit about whether this is time now for us to think of changing the context of thinking about autonomy and trust here. It's not so much about individual choice anymore. The adjudicatory, the kind of sanctions, regulatory language makes all kinds of collaborative relationships very difficult, if not possible. So I want to look at a more of a deliberative democratic process and see how that may be able to help us to think a little bit more of restoring or maintaining trust in the system. So in political philosophy, there are people who have talked about how public engagement in many ways can actually enhance the legitimacy of the process. I want to think about whether we think that that perhaps can also add some kind of legitimacy in terms of various scientific research. So public engagement can perhaps get people of different groups, especially marginalized groups, to express their concerns, their values, and priorities. And so the kind of engagement that I'm thinking about is more about substantive issues rather than trying to increase participation here. So instead of just focusing on individual consent, in a situation where the whole research agenda is already set up, there may be questions about whether we want to think of research and consent perhaps more as a public kind of consent. So I actually perhaps want to think a little bit about whether we should think of research as all community-based. And right now we have community-based research and non-community-based research. And I often wonder why there should be certain kinds of research that is not community-based, especially if so much money is actually being poured into it. Now, of course, there may be also concerns right now, it's perhaps a big concern, in terms of who may be actually the relevant communities for engagement. And so this may also depend on the particular type of research that we're thinking about. But maybe we can talk a little bit about this in the Q&A. Transparency may also be another way to help us to re-examine the way that we're thinking about the research process here. And transparency, I'm not even just thinking about disclosure, but really as a way to foster various kinds of public engagement. It's only when people actually know what some of the hidden kinds of relationship may be, works on the ghostwriting and situations. Most people actually don't know anything about that, especially people who are engaging in clinical trials. They don't know what other kinds of relationships that the researchers and physicians may have with the funders, other institutions, and the peers, and so on. So I think about transparency in terms of actually bringing some of those things into the foreground and enhancing the public engagement. And now I'm thinking about these three elements as all interrelated here. So you can't have just one and not the others. And I'm thinking about when I think about accountability in this kind of democratic approach, I'm thinking about accountability in terms of responsiveness. So responding actually to what the community may need, and not just in terms of where the money is. There have been lots of studies about how most of the research, pharmaceutical research, is more on the so-called lifestyle drugs than actually various other kinds of essential medicine. So that accountability is also about the use of the appropriate use of epistemic authority and balancing the existing power. So even though there may be some kind of power hierarchy right now because of the profession, but there may be also a need to think about how the profession is there to respond to the need of the community. So to think of each other as moral equals. So accountability here is not just about sanctions, but more about fostering mutual exploration that allows disagreeing parties to actually see what are some of those possibly incommensurable values. And so that can help us also to find out what may be some of the potential problems before things actually get out of hand. I probably don't have time to get to this right now, but this is part of what I'm thinking about, that I want to acknowledge the dependency as being inevitable. I know that many people are very concerned about that and want to try to say that perhaps we need to get rid of that dependency in the professional kind of relationships. I don't think that is actually possible. So what I want to argue is that perhaps the focus really should be more about the trustworthiness of the institutions and the professionals who are working within them. And more thinking about how do we have responsive use of the expertise and changing the culture of medical science instead of just having regulations. That's it. Thank you.